Thank you for inviting me to this very important meeting, the fifth Ruijin International Thoracic Symposium. And today's my talk will be about the neoadjuvant treatment in thymic epithelial tumor. And thymic epithelial tumor is a relatively uncommon tumor, and in case of the very extensive disease, neoadjuvant treatment has been applied in a common practice. And today, my talk will be about the review of current evidence and some of the controversy in the neoadjuvant treatment. Advanced thymic epithelial tumors are presented in 10 to 30% of the patients. So neoadjuvant treatment is usually considered in unresectable or marginally resectable cases. Neoadjuvant chemotherapy or chemoradiation can be applied according to the disease status and general condition of a patient. The goal of neoadjuvant treatment is to improve complete resection rate. However, currently there is no evidence of superiority of neoadjuvant treatments over upfront surgery. This is a CT scan of patients with advanced thymic epithelial tumor. A tumor is located in the right side of the heart, and tumor is encasing ascending aorta and superior vena cava. And also, tumor is invading the right hilum in very deep position and penetrating right pulmonary artery and bronchus. In this advanced case, upfront primary surgery can be tried. However, and usually complete resection is not possible. And so today's talk is about these kinds of very advanced tumors which primary resection may be not possible. In neoadjuvant treatment, the first thing what you should determine is the indication. What will be the indication of neoadjuvant treatment in thymic epithelial tumor? I think some patients in T3 and almost all patients in T4 can be indication of neoadjuvant treatments. In this table, this shows the invaded organs which can be involved in the thymic epithelial tumor. As you can see in the table, most common organs involved is lung. Lung is around half of the patients. It shows lung invasion in advanced thymic tumor. The next one is the pericardium. The next is the superior vena cava. And as you can see, the most of the organs that can be invaded is T3 organs. However, in most of the cases of lung invasion and pericardium invasion, usually primary surgery is enough. However, in some cases of superior vena cava and most cases of aorta and main pulmonary artery invasion, usually induction treatment may be necessary. So my opinion and of the indication is and some part of the advanced T3 and most of the patients with T4, I think. Before reviewing the result of neoadjuvant treatment, I think we must review the outcomes, result of upfront surgery. This paper is about the upfront surgery in the advanced thymic epithelial tumor and published by the Japanese database from JART. They included 310 patients with advanced thymic epithelial tumor. Most of the patients received upfront surgery, and they draw a table according to the invaded organs. And you can see that in the lung invasion, complete resection rate was 82%, and pericardium invasion, the complete resection rate was 85%. However, in the invasion side was a great vessel and phrenic nerve and chest wall, the complete resection rate decreased. And this data shows that according to the invaded area, complete resection rate can be differs from other invaded area. So I think the great vessel invasion and phrenic nerve invasion and chest wall invasion can be a good candidate for the neoadjuvant treatments. Here, plane of invasion represent deep hilar invasion. One more thing, what we should remember is the number. The complete resection rate of the upfront surgery is around 70 to 80% in upfront surgery. So it will be better to remember the number 70, complete resection rate. To understand the outcomes of neoadjuvant treatment, we should know how to measure the outcome response. We have two methods to evaluate the outcomes of the neoadjuvant treatment. The first one is a radiologic response evaluation. The second one is a pathologic response evaluation. This table shows the most famous radiology response tool, the RECIST criteria. epithelial usually recommend use the RECIST criteria in the thymic epithelial tumor response. This RECIST criteria is composed of the four stages, the CR, PR, PD, and SD. The PR is a decrease in the sum of diameter and 30% or more, and the PD is an increase of diameter 20% or more. This is a very famous table, so I think the most of the audience already knows this. However, there are several differences between RECIST criteria and epithelial recommendations. In RECIST criteria, and they usually recommend to measure long axis of pleural metastasis. However, in epithelial, they recommended using the short axis in pleural metastasis, and the maximum number to be measured in pleural metastasis is 2 in RECIST criteria. However, it is 6 in epithelial recommendation. So as for the diameter measurement and the number of to be counted in the measurement is epithelial is quite different from RECIST criteria. This is the actual measurement example of thymic epithelial tumor. The patient had an 8 centimeter thymic tumor and 2 centimeter pleural metastasis and 1.7 centimeter of nodal metastasis. And so some of the diameter was adding the long axis of the primary tumor and short axis of pleural regions and the short axis of lymph nodes. So the sum was 14.1. After neoadjuvant treatment, the tumor size long axis decreased to 4 centimeter and pleural metastasis and lymph nodes also decreased. So sum of diameter became 7.6 centimeters. So 46% decrease was identified. So overall assessments of response is a PR, partial response. The reason why I am showing this figure is that in most of the papers they ignored adding the metastatic lesion. They just some papers just measure primary tumor. So it is very important to strictly follow the epithelial guideline to objectively compare the outcomes between different institutions. So this is why I'm showing this figure. This is a graph that shows the tumor size decrease after neoadjuvant treatment. We included 56 patients who received neoadjuvant chemotherapy in our hospital. As you can see, the graph, around 20% of patients did not show any change. And the maximum decrease of the tumor size was 60%. And so 40% of tumor still remain in a maximum response case. So when you consider the major pathologic response, the more than 90% cancer cell death is a most important prognostic factor in neoadjuvant treatment. So we could not get any patient who could achieve the major pathologic response in our data. So I think the response rate of the thymic epithelial tumor to the chemotherapy is still the modest. So it's not very good compared to other cancer. It's our impression. Some papers reported downstaging can happen after neoadjuvant treatment, and some patient shows the downstaging, so it is a direct evidence of the neoadjuvant treatment effect. However, in our paper, we compared the downstaging rate in the neoadjuvant treatments and upfront surgery. We could find out that many patients are downstages even after upfront surgery. The downstaging can happen after neoadjuvant treatment. However, we think most of the downstaging happens because of the inaccuracy of CT staging. Because current CT staging does not accurately predict the invasion to adjacent organs, so usually it has tendency to overestimate the invasion. So we can experience many downstaging after operation, even in the primary surgery. So I think downstaging cannot be a objective indicator of the neoadjuvant treatment effect. The second way to evaluate neoadjuvant treatment is a pathologic response assessment. Usually, in most centers, the Mandad classification is used to assess the pathologic response, and the Mandad classification is graded from TRG grade 1 to TRG grade 5. And in most cases, major pathologic response is considered as a good candidate, good prognosis group after neoadjuvant treatment. The TRG1, the proportion of TRG1 and TRG2 is important for the improvement of the treatment outcome. This is the graph showing the pathologic response after neoadjuvant treatment. In this graph, you can see the complete response rate was just 6%, and the TRG grade 2 is 10%. So maybe major pathologic response is around 15% after neoadjuvant treatments. So 85% of the patient shows no response, only just a small response after neoadjuvant treatments. And when we considering the radiologic response and pathologic response of neoadjuvant treatments, it was my impression that the benefit of neoadjuvant treatment may be very small in thymic epithelial tumor. So let's look at the outcomes of the neoadjuvant treatment. This is a paper published in 2016, including around 12 papers. Most of the papers are retrospective papers, and as you can see in table 1, the numbers of patients included in the paper is around from 10 to 38, and all of the papers are very small series of papers. And in the table B, you can see the complete resection rate, average complete resection rate was 73%. And in the first part of my presentation, I recommend you to remember the number 70. It's in upfront surgery in a very highly advanced stages of invaded organs. Average value of the complete resection rate was 70% in JAT database. So considering number 70 in the primary surgery, 73 is another so impressive number and of the induction treatment. And after that neoadjuvant treatment, I summarized papers on the neoadjuvant treatment published recently, and some papers from Japan and China and America and Korea, and most of the papers included a small number of patients. Some centers use chemo and chemoradiation combination, and some centers use chemotherapy only. And as you can see there in the table, the RJ rate was around 60, late 60%, is even could not reach the 70%. 5-year survival is around 70%. The rest paper published in 2019 included 109 patients. This paper is my paper, and we used chemotherapy and as a neoadjuvant treatment, and the more 58% of the patient was stage 4 and the most advanced stages, and arterial resection was 63% and 5-year survival was 77%. My real question on the induction treatment is that whether induction treatment really improved the survival of the patients. So using the database, we compared the upfront surgery and induction treatment using the propensity score matching analysis. And as a result, we could not find any benefit of the overall survival or recurrence-free survival. As otherwise, the induction treatment group shows a poorer survival than the upfront surgery. And the limitation of this paper is that this is a retrospective paper, so we don't know whether the induction treatment group had more advanced stages. Even in the same clinical stages, maybe the tumor had more advanced stages. So, however, this is best evidence currently. So, in the current status, we have no evidence that induction treatment is better than upfront surgery, I think. Neoadjuvant chemoradiation can be another option of induction treatments. It was first published in 2008, only including a small number of patients, around 10 patients. And then after 5 years later, a second paper publishes in 2014. According to the paper published in 2014, 22 patients from the 4 institutions were included. They used cisplatin and etoposide 2 cycles and 45 grade radiation. Around half of the patients showed partial response, and arterial resection rate was 77%. That's good. However, unfortunately, and post-operative complication rate was 36%, and even post-operative mortality was 9%. It's significantly high, I think. So maybe induction chemoradiation can improve the response rate, a slight improvement over the complete resection rate. However, otherwise, induction chemoradiation has a risk to increase the post-op mortality and complication rate. So in this issue, I think we need more paper, more study on the induction chemoradiation in the thymic epithelial tumor. Okay, let's get back to the original case. In this case, we used neoadjuvant chemoradiation. The problem of neoadjuvant chemoradiation is the radiation field. As you can see, this field design, and the significant portion of lung are involved in the radiation field, and the significant area of heart is also involved in the radiation field. It is because the tumor is very large, and because of large size of the tumor, the radiation field increase, so side effect can be increases in the radiation. It is quite different from esophageal cancer. In most of the cases of esophageal cancer, the field of radiation is very, very small, so side effect is can be minimized. The other problem is usually we use a CAP regimen includes doxorubicin. Doxorubicin is very notorious for the cardiac toxicity. So it can have a synergistic effect in the cardiac, deteriorating the cardiac function. So postoperatively the cardiopulmonary complication can be increased after induction chemoradiation. Whatever, we did the operation, we resected the tumor and superior vena cava, and we did the right pneumonectomy. You can see the surgical specimen here. In the cut surface, the tumor was widely infiltrating the lung and invading the common pulmonary artery trunk and the main bronchus. This is a pathologic report of the patient. In the left slide, you can see the mixture of epithelial and the spindle cell. In left side, you can see the spindle cell and a mixture of the myofibril, and right side, you can see the epithelial component. In the immunohistochemical staining, the strong staining for cytokeratin. So after thorough evaluation of the specimen. Our pathologist conclusion was a metaplastic thymoma, because this is a really very rare thymoma. So I don't know, but my pathologist concluded it is not a sarcoma, not a carcinoma, just metaplastic thymoma. The tumor response grade was 4. As you can see, there was no necrosis. Almost all tumor cells are alive, so it's a very minimum response to neoadjuvant chemoradiation. The size was 9.8 centimeter, and the T&M stage was T3N0M1B, and complete resection was possible. And this is a usual pattern of the pathologic specimen after neoadjuvant treatment, and induction tumor response grade very minimized, and the downstaging is unusual. And so what the meaning of the neoadjuvant treatment should be clarified in the next studies or trial. So I must conclude my talk. And neoadjuvant treatment, especially chemotherapy, can be delivered in case of marginally resectable thymic epithelial tumor. This is a very common practice. However, the response to chemotherapy is modest, and overall survival benefit is unclear currently. Neoadjuvant chemoradiation can be considered as an alternative treatment. However, increased postoperative complication and mortality should be considered. The ultimate goal of induction treatment is to increase the complete resection rate, and surgeon should play a main role when selecting proper treatment for the patients with advanced TT. Thank you for your attention.